Hello, my name is Michal Kovu. I'm the head of Labor and Delivery Ward in Wolfson Medical Center in Holon, a city near Tel Aviv. I'm one of the leading authors, together with Professor Simcha Yagel and Dr. Ofer Beharir from Hadassah Medical Center, and with Professor Michal Neman and Dr. Romina Plittman-Mayo from Weizmann Institute of Science, of this national multi-center project discovering efficient maternal to neonatal transfer of antibodies against SARS-CoV-2 and BNT mRNA COVID-19 vaccine. Recent data demonstrated that pregnant women with COVID-19 infection are at increased risk for intensive care unit admission, mechanical ventilation, and death compared with properly matched non-pregnant women. COVID-19 illness increases the risk for pregnancy complications such as preterm birth, pregnancy-induced hypertensive diseases, and thromboembolic diseases. The CDC included pregnancy as a risk factor for severe COVID-19 illness, a statement that was also acknowledged by the American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, and other women's health organizations. In an attempt to stop the COVID-19 pandemic spread, mass vaccination campaign commenced worldwide. Randomized clinical trials reported efficacy of 94 to 95% for mRNA-based vaccines. However, these studies excluded pregnant women. Nevertheless, following extensive discussion regarding the risk of COVID-19 during pregnancy, potential vaccine benefits, and safety concerns, the CDC, the Israel Ministry of Health, and other health organizations advised that COVID-19 vaccine should be offered to pregnant women. Accordingly, a vaccination campaign among pregnant women in Israel began in December 2020. As we lack sufficient evidence regarding vaccine effectiveness in pregnant women and their offspring, we aim to provide substantial evidence for the effect of BNT mRNA vaccine versus native infection on pregnant women. Specifically, we aim to characterize maternal humoral immune response to BNT mRNA vaccine and natural SARS-CoV-2 infection during pregnancy. We aim to describe the transplacental acquired fetal immune response. This was a nationwide collaboration between 8 medical centers in Israel, Weizmann Institute of Science, and the Correct School of Veterinary Medicine and Robert Smith Faculty of Agriculture, Food, and Environment of the Hebrew University of Jerusalem. Pregnant women admitted for delivery were approached for enrollment in the study. Eligibility criteria included an age of 18 years or older and the willingness to participate and provide informed consent. Pregnant women with active maternal COVID-19 disease at delivery were excluded from this study. Maternal and cord blood samples were collected prior to delivery and following delivery between April 2020 and March 2021. IgG and IgM were tested for S1, S2, RBD, and N antigens. Notably, anti-N antibody is present only in those who were exposed to the virus. IgM is known for not crossing the placenta. The cohort consisted of 1,094 participants, 105 vaccinated women, 94 unvaccinated participants with past SARS-CoV-2 positive RT-PCR results, and 895 unvaccinated without prior documentation for infection. Matched maternal cord blood serology results were obtained for 213 DIADs, 65 with past COVID infection, and 86 vaccinated women, 3 of which were also PCR positive during pregnancy, and 62 non-infected unvaccinated controls. Among the 895 non-infected unvaccinated participants, 66 were selected as the matched comparison group, but 4 were later excluded due to lack of matched maternal cord blood serology results. The control group was matched to the vaccinated group. Clinical parameters did not differ among the groups except for maternal age, which was significantly lower in the SARS-CoV-2 group as compared to the other 2 groups. Notably, mean gestational age for PCR past SARS-CoV-2 group was 28 weeks, and mean gestational age for the first vaccine dose of the vaccinated group was 34.5 weeks of gestation. Maternal and cord blood serological IgG response to S1, S2, RBD, and N antigens were derived at the time of delivery from 65 patients who had COVID-19 during pregnancy. The data were analyzed by the gestational age of PCR diagnosis to reveal possible changes in the humoral response of infection biology across pregnancy. Based on serology analysis at delivery, transmission rates of all antigens were significantly higher in participants who were PCR positive to SARS-CoV-2 prior to 30 weeks of gestation as compared to gestation above 30 weeks. The multiplex immune response was used for further clustering of the participants based on reactivity to the N antigen. As mentioned, anti-N presents only in those who were infected by COVID-19, but not in vaccinated women or controls. Multiplex serological IgG and IgM response to S1, S2, RBD, and N were tested in maternal and neonate. Each row represents matched maternal fetal data ranked by the maternal IgG reactivity to N antigen, within each group low reactivity in green and high reactivity in red. Note, 40% of the controls were found to have pre-existing induced immunity due to infection. Also, 7 patients of the vaccinated group were seropositive for N, of which 3 were also PCR positive. Notably, 4 neonates of the PCR positive group were identified with robust IgM response to all SARS-CoV-2 antigens. This consistent with compromised placental barrier, fetal exposure to viral antigens, or vertical viral transmission. This is another presentation of the cluster analysis of all study participants by maternal response to N and RBD. Low IgG for N and high IgG for RBD was found for the majority of the vaccinated patients, upper left corner blue dots. The unvaccinated control group, which showed no humoral response, indicative of prior infection, cluster in the bottom lower corner in red. Since N is present in the intact virus but is not included in the vaccine, high IgG titer for N reveals patients exposed to the virus. On the other hand, RBD is present in the vaccine as well as the virus. Thus, high IgG for both RBD and N reveal a small number of patients exposed to the virus within the control group, the red dots, as well as vaccinated, the black dots, which cluster with the PCR positive group, green upper right cluster. The temporal dependence of the acute maternal response to SARS-CoV-2 infection days 1 to 45 was compared to the response to the 2-dose regime of vaccine, where the first vaccine is administered on day 1 and the second dose on day 21. A gradual rise in IgG humoral response, anti-S1, S2, RBD, and N, during the first 45 days after infection is illustrated in A. In the same time period, vaccinated participants show a rapid IgG response to S1, S2, RBD, but not N, resulting in high titer values by day 15 after the first dose. A further rise in IgG was observed following the second dose in figure B. The temporal dependence of fetal IgG for S1, S2, and RBD after maternal vaccinated trailed and is illustrated in figure C, showing a significant response already by day 15. As expected, a further increase was observed following the second vaccinated dose. Paired maternal neonate serological data were grouped for statistical analysis to control, as well as to mothers who presented a delivery within the first 3 weeks after the first vaccine, deliveries during the first week after the second vaccine, and fully vaccinated deliveries more than 1 week after the second vaccine. Significant increase in maternal and fetal IgG and maternal IgM to S1, S2, and RBD, but not N, were observed already after the first vaccination dose and persisted at later time points. Fetal IgM response to BNT antigens S1, S2, RBD was negligible, consistent with no evidence for direct exposure of the fetus to vaccine-derived antigens. As illustrated in here, at the time of delivery, maternal IgG for S1 and RBD were significantly higher in vaccinated women, while IgG for S2 and N were significantly higher in PCR-positive women. Fetal IgG for S1 and RBD did not differ from those of PCR-positive women. Next, the serological response to cord blood correlated positively with the maternal humoral response for IgG against all the analyzed antigens. There were no differences between the correlation slopes of the SARS-CoV-2 infected group versus the vaccinated group for any type of antibodies, suggesting similar placental antibodies transfer following SARS-CoV-2 infection and vaccination. The next video demonstrates the IgG transfer ratio for the PCR positive group and for serologically positive and negative vaccinated groups. Note that the transfer rate for N in the N group is not presented due to the low seropositivity. Significant differences were found for S1, S2, and RBD between the PCR positive and vaccinated anti-N groups. The transfer ratios for all antibodies did not differ between the vaccinated anti-N and all the other groups. In conclusion, maternal and cord blood anti-COVID-19 antibodies generated in response to a second trimester SARS-CoV-2 infection, as well as transfer ratio, were high at the time of delivery. There is a low transfer ratio for infection during the third trimester, yet this could reflect a lag in antibody transfer across the placenta. Persistent humoral immunity for infections during the second trimester of pregnancy may be informative prior to boosting previously infected pregnant women. We found that COVID-19 mRNA vaccine elicits a rapid rise in IgG titers and effective transfer across the placenta, exceeding the transfer rate observed in pregnant women with third trimester SARS-CoV-2 infection. BNT mRNA vaccine elicits strong maternal humoral IgG response within 15 days following the first dose. IgM response in the fetus was detected only in the infected group. The present study has several limitations. First, bias in sample collection, as the most of the study's recruitment occurred during the day and therefore not including most of emergency cases. However, the method sample collection did not differ between the study groups and medical centers, thus minimizing the impact of this effect on our results. Second, since sample collection began long before the COVID-19 immunization campaign, the duration of sample collected differed somewhat between the groups, with an extended recruitment period for COVID-19 recovered cases. We found no differences in background or demographic parameters among the groups. Third, history of COVID-19 infection during pregnancy was made by positive RT-PCR results during pregnancy with self-reporting of the time of PCR test. Fourth, patients presenting with RT-PCR positive within 1 week prior to delivery were excluded from this study due to safety concerns. Thus, future studies are needed in order to characterize the maternal humoral response to COVID-19 within days of infection. The strengths in the study include its multi-center design, our relatively large cohort size, and our diverse patient population. We would like to thank the patients who made this research possible. We also would like to acknowledge the contribution of other participants in patient recruitment, sample preparation, and discussions. This work was supported by ISF Kiel Corona Grant and by a research grant from Fundación Heinrich Mitterrand. We thank you for your attention and take care.